Hello. My name is Dr. François Ricard. I am an osteopath and a PhD. I am director of the International Madrid School of Osteopathy, EOM, and president of the Scientific European Federation of Osteopaths, SCFO. In this video, I want to talk to you about mechanism of action for HVT used to treat disc herniations. This series of videos will look at the scientific literature surrounding the mechanisms of spinal manipulations, mostly used by osteopaths and chiropractors. In these videos, we will study the mechanical mechanisms of action for disc hernias, and the effects they have on the peripheral and central nervous systems, the neuromuscular, biological, and neurovegetative systems, and on the organs. In this second video, we are reviewing the mechanisms of action of spinal manipulation used to treat disc hernias, HVT. Contributing factors for disc resorption. According to Ninemide et al., 1999, the factors that contribute to disc resorption are the recent formation of blood vessels in the area of inflammation, angiogenesis. The presence of fibroblast growth factors. According to Bozow et al., 1992, 68% of disc herniations reduce in size by more than 30%, and 48% reduce by more than 70%. Saal et al., 1990, indicate that 11% of patients presented a reduction of between 0 to 50%, 36% presented a reduction of between 50 to 75%, and in 46% of patients, the reduction was between 75 to 100%, with the greatest reduction corresponding to the craniocaudal diameter. Modic et al., 1995, studied 25 patients, and 80% improved with conservative treatment. Wu et al., 2012, studied changes in intradiscal pressure in cadavers in the C3-C4, C4-C5, and C5-C6 discs, using micropressure sensors, during the different stages of a cervical manipulation. They studied 5 different cervical positions: extension 20 degrees, extension 10 degrees, neutral position, flexion 10 degrees, flexion 20 degrees, and 3 different turning times: 0.06, 0.11, 0.16 seconds. Intradiscal pressure was lowest at 20 degrees extension, combined with a turning time of 0.16 seconds. Different cervical positions, turning times, and cervical segments largely influence intradiscal pressure during the process of spinal manipulation. The study by Beneliyahu, 1994, indicates that patients with and without nerve root compression secondary to cervical disc herniation can and do respond well to chiropractic care. Chiropractic management of this condition can and should be employed prior to more invasive treatment. Yi et al., 1990, treated 35 patients with lumbar disc herniations using spinal manipulation, and found that in 29 cases, 82.8%, the CT scan showed a reduction and repositioning of the disc hernia. The hernia was completely reabsorbed in 6 cases, and there was a partial reduction in 24 cases. The success rate of the reposition by manipulation was 83.3%. Lehman et al., 2014, reported significant improvement in all of the patients with disc herniations. At 3 months, 90.5% of patients were improved, with 88.0% improved at 1 year. Although acute patients improved faster by 3 months, 81.8% of chronic patients reported improvement, with 89.2% improved at 1 year. There were no adverse events reported. In 4 patients, there was no improvement, and they were treated with surgery. According to Yang et al., 2013, conventional acupuncture and spinal manipulation achieve quick and good efficacy in lumbar disc herniations, and improve the quality of life for the patients to a certain extent. The analgesic effect of this therapy is relevant, with the decrease of serum TNF-alpha. According to Peterson et al., 2013, most spinal manipulation and nerve root injection in patients with radicular and low back pain and magnetic resonance imaging confirmed disc herniation reported significant and clinically relevant reduction in self-reported pain level. There were no significant differences in outcomes between spinal manipulation and nerve root injection. Considering the direct costs of the procedure, the average cost of spinal manipulation was lower. Main and Guion, 2000, showed that during a thrust, relative intervertebral movements were demonstrated. Movements differed with the type of manipulation, inflection or extension. Intradiscal pressure initially increased, then decreased. Images show manipulation in lumbar flexion and extension used in the study by Main and Guion. Main and Guion, 2000, showed that lumbar spinal manipulations have a biomechanical effect on the intervertebral discs, producing a brief but marked change in intradiscal pressure. The reduction in intradiscal pressure can be enough to reduce a disc herniation. The diagram indicates changes in intradiscal pressure during a HVT maneuver in flexion, cadaver 2, according to Main and Guion. The black arrow represents the beginning of the thrust, as seen in the accelerometer data. The curves show changes and not absolute values. Ricard, 1998, studied the results of an osteopathic treatment protocol that included spinal manipulation and flexion distraction in 690 patients with disc herniations, and described a significant clinical improvement in 91.32% of cases. In 60.98% cases, the pain disappeared completely. They resumed normal life and returned to doing sports with no limitations. MRI showed that the size of the disc herniation was reduced in several patients. The study by Zhang et al., 2011, showed that spinal manipulation combined with traditional Chinese physiotherapy and traction can improve visual analog scale results in cases of lumbar disc herniations. The objective of the study by Zhang et al. Was to observe the morphological change of prominence through CT three-dimensional reconstruction, before and after manipulative treatment. In 79.2% of patients, morphological changes were identified after the treatment. Standard manipulation can make prominence change, the prominence and nerve roots release, and mutual position improve, which can provide imaging evidence for the study in biomechanical effects. According to Feng et al., 2012, spinal manipulation with HVT causes the relationship between the nerve root and the herniation to change, followed by a subsequent change in the mass of the hernia. In the study by MC Moreland et al., 2010, 60% of patients with sciatica benefited from spinal manipulation, showing a positive result. The study by Li et al., 2010, shows that manipulative treatment on lumbar disc herniation is safe, effective, and both cure rate, and the effective rate is better than other therapies. According to Mo et al., 2018, in the treatment of lumbar disc herniation, oblique pulling spinal manipulation presented with a higher effective rate than acupuncture and lumbar traction. Manipulation had a favorable effect in alleviating pain, and modified oblique pulling manipulation had significant superiority in improving lumbar function, when compared with lumbar traction. According to Chen et al., 2028, low-quality evidence suggested that surgical treatment is more effective than non-operative treatment in improving physical functions. No significant difference was observed in adverse events. No firm recommendation can be made due to instability of the summarized data. Chokri et al., 2018, indicate that 5 sessions of lumbar and sacroiliac joint manipulation can potentially improve pain and functional disability in patients with MRI-confirmed lumbar disc hernia. Conclusions? Although we have not looked at every scientific study on this subject, there is proof that spinal manipulation is an effective treatment for disc herniations. Spinal manipulation reduces low back pain and sciatica and, in certain cases, reduces the size of disc herniations. Given that the results of surgical treatment for disc hernias are not good in terms of improving low back pain, all surgical intervention should be carefully considered when conservative treatment has been shown to be highly effective. Here you can see a list of all the references used for this presentation. Thank you for listening.